Radio, I think we can start.
Okay, welcome all to the Symposium on Deep Brain Stimulation for Movement Disorders. About 6 lectures are ahead of us. The objective of this symposium is to look to deep brain stimulation from a neuroimaging perspective. We'll start with the lecture from Vladimira Vuletić, non-motor symptoms in Parkinson disease and Dystonia, neuroimaging perspective. Vladimira Vuletić is an associate professor of neurology and also a director of the Department of Neurology in the University Center of Rijeka, interested in movement disorder with a special interest of movement disorders and deep brain stimulation.
So welcome also from my side. The symposium, we cover a few topics. There will be a reviews with a touch of our research as well. I just want to invite everybody to forward us questions writtenly, and the discussion will not be after each presentation, but at the end. So when you ask a question, please mark for which one of the speakers do you expect the answer. Thank you very much. So I welcome Professor Vuletić.
Yes, so unexpectedly, it's my honor actually to introduce Professor Maja Trošt. She's the head of the Center of Movement Disorders at the Department of Neurology, University Medical Center of Ljubljana, and also, as I said, a professor of neurology at the University of Ljubljana. She has introduced many different techniques for the treatment of late-stage Parkinson disease, starting with duodopa, deep brain stimulation, and the others. She's going to give a talk on the effect of deep brain stimulation on brain metabolism in movement disorders, as she's an experienced researcher in the field of functional imaging in movement disorders. Please go ahead, Professor Trošt.
Thank you very much. Now I'm going through the same procedure as Vladimira was trying. So, is that okay? Can you see my screen?
Yes, yes, yes.
Okay. So thank you very much for the introduction. I'm going to talk to you in the next 15 minutes or so about 3 different topics that may seem unrelated. This is deep brain stimulation, brain metabolism, and movement disorders. But if we join all those 3 topics or areas, we as a clinician and as a researchers can gain an important information about the mechanism of treatment of movement disorder, side effects, of which this just few words for the general audience what we mean when we talk about movement disorder. Usually we mean the neurodegenerative disorders affecting primarily deep brain nuclei in the brain, the so-called basal ganglia, and the most common neurodegenerative movement disorder is Parkinson disease. Parkinson disease, similarly to other neurodegenerative brain disorders, is a proteinopathy, and in Parkinson disease it is the alpha-synuclein, which is the protein that accumulates abnormally throughout the brain. And what brings us to the clinical presentation of Parkinson disease. Parkinson disease is one of the functional network disorders. Basal ganglia, as you can see on those 3 pictures, are functioning as part of the loops. They are very well connected with other brain areas that don't control only our movement, but also our mood and our cognition. Deep brain stimulation is not anymore novel, but I'm trying to learn myself that I have to say that it is now standard neurosurgical treatment of Parkinson disease and other movement disorders in the stage when oral treatment doesn't help patient enough or doesn't improve patient's quality of life enough. In deep brain stimulation, the neurosurgeon inserts a thin electrode deep into the nuclei, which is then stimulated through the pulse generator, which is implanted under the skin on the chest. What we know about deep brain stimulation is that its response is not only, that its effect is not only local on the nucleus that is being stimulated, but it spreads along the loops that I already mentioned, and it really causes a neuromodulation of nervous system. We don't know many things about how deep brain stimulation works, but as a clinicians, we don't care as long as it works, if I'm being a little bit sarcastic. But what we know is that effective stimulation is the one at really high frequency, much higher than are the normal frequencies of oscillatory activity of human deep brain nuclei. It's an oversimplification that the deep brain stimulation causes the depolarization of axon and inhibition of cell body. But again, what we know very well, that its activity really projects throughout the brain away from the target. If I want to just touch a little bit more molecular level of deep brain stimulation, we know that it causes changes in ionic currents. It has effect on various non-synaptic mechanisms, causing excessive extracellular levels of neurotransmitters and ions, and also that the environment that it causes is it favor in development of plasticity. And we can even observe that in some patients in whom we observe that after switching deep brain stimulation off, the therapeutic effects last for some time. The indication for deep brain stimulation are numerous in the field of neurology, psychiatry, and the new are emerging. And those written in blue are the indications that are approved by Maja in Europe and FDA in US. So what about imaging? Imaging plays an important role in different stages of treatment with deep brain stimulation, from finding the right target, pre-surgical, neurosurgical planning for the insertion, target selection, but also following the deep brain stimulation, checking the effect and searching for clinical correlation. Today, I'm mainly going to talk about brain metabolism imaging that we gain by FDG PET imaging. And here you can see on the upper row the FDG PET scan of a normal subject, and below is the Parkinson disease patient. And without going into details, I think everybody can see that there is a difference in brain metabolism caused by lack of dopamine, caused by degeneration deep in brain in substantia nigra, but the whole brain can feel the consequences of this dopaminergic lack. Since deep brain stimulation came to the market, it was, we were asking questions, how it works. Does it work the same as levodopa does? And this is a result of an older study where the researchers, sorry, I can hear the technical room, sorry. The researchers tested with checking the brain metabolism, how levodopa affects the brain metabolism and how does deep brain stimulation of subthalamic nuclei. So this is the scan of the Parkinson disease patient, and you see the regions that levodopa decreases, increases or decreases. We're talking about brain metabolism, and you see that deep brain stimulation does different things to the brain, although the clinical improvement by deep brain stimulation of subthalamic nucleus or levodopa may be very similar or even identical. The mode of action is not the same. So brain metabolism can teach us about the mechanism of different treatments. Besides looking to the brain as a whole visually or observing the activity of the separate brain region, we can also apply different analytical techniques to the brain scans. And one of those was presented yesterday by my colleague Matej Peronik, who kindly borrowed me this slide, which shows the principles of the so-called SSM-PCA analysis, where the statistical toolbox can extract from a group of patients and healthy controls a specific metabolic pattern that is characteristic for this specific patient group. And we can use this as a biological metabolic marker of specific disease. And one of the first metabolic patterns identified and then many times replicated by different groups was a Parkinson disease-related pattern. This is the pattern that, that presents the abnormally hyper or abnormally hypoactive brain region that are functionally connected with each other. And this particular pattern is more expressed in Parkinson disease patients compared to controls. These are the results of our group, where we identified the pattern and validated on additional healthy controls, Parkinson disease patient, atypical Parkinsonism, so patients who don't have Parkinson disease and also don't have this pattern. And what is also important, the expression of this pattern correlates with clinical expression of Parkinson disease. So can this particular pattern be a biomarker also of the effect of deep brain stimulation? In this study that was performed some years ago, the effect of lesioning subthalamic nucleus, which was performed earlier before deep brain stimulation came to clinical practice, was compared. And we can see that this is the pattern, and the expression of the pattern falls more than after lesioning than the stimulating the nuclei. Or in a similar study, levodopa infusion, the effect of levodopa infusion on Parkinson disease-related pattern was compared with STN-DBS, and of those patients, 3 got additional levodopa infusion on top of DBS, and the pattern fell even more. Here on the right side of the slide, you see the comparison of changes in PDRP after deep brain stimulation or lesioning 2 different nuclei, GPI, globus pallidus pars interna, which can sometimes be used. And we know that for a similar clinical effect, we need usually to add levodopa for the patients, because stimulation or lesion of GPI is not decreasing this pathological Parkinsonian pattern as much as lesioning or stimulating STN. What about long-term effect? This is a recent study which with the pattern that was identified by a Chinese group. And maybe you can pay attention to this right graph. 3 months after surgery with stimulation off, so not working, the pattern decreased, but later started to increase again. So meaning that just inserting the needle to the brain without even switching it on can decrease the activity of the pattern, which we also clinicians see by the so-called lesion effect. And sometimes we insert the electrode and the patient's condition improves temporarily. We can also target other brain nuclei. VIM, thalamic nucleus, can be stimulated to treat tremor. And this is the study on a tremor patients where the stimulation was switched on. The tremor pattern, which looks like that, it decreased very much. And interestingly, the tremor pattern also decreases more when we stimulate the thalamic nucleus than STN-DBS, and it's the vice versa with Parkinsonian pattern, which decreases more by stimulation of the subthalamic nucleus compared to thalamic one. We can also follow the metabolic correlates of specific consequences of deep brain stimulation. This is an interesting study where they were following 20 Parkinson disease patients after STN-DBS, and half of them lost or their drawing ability decreased. You can see their drawing is before and after deep brain stimulation. And those who lost their drawing ability had a decrease of the stimulation in Brodmann area 24, which is part of the cingulate circuit connected to the limbic part of STN, which can sometimes be accidentally stimulated when we perform STN-DBS to treat motor parts of Parkinson's disease. There is always, when a new treatment comes to market in Parkinson's disease, a question: could it be neuroprotective? So could DBS be neuroprotective? Do we have any evidence of that? For the treatment to be neuroprotective, we know that it could affect either disease pathogenesis, it should reduce the rate of neuronal loss, or it should be associated with slower symptom progression or increase the survival. For STN-DBS, it has been shown that it may protect the substantia nigra part compacta by reducing exotoxicity from the overactive glutamatergic projection that calm down, to say so, with STN-DBS, and it may promote the survival of the neurons by releasing neurotropic factors. Because this neurotropic threat for release occur at the dendrites, this may give us an information that it would be better to treat with STN-DBS patients rather earlier, where more dendrites are still present to exhibit this neuroprotective effect. But certainly more studies would be needed to prove that, and imaging as an objective marker of disease could help us a lot. I just want to close by showing you the number of clinical trials on deep brain stimulation, which the majority of them are on the field of movement disorder, but this type of treatment spreads to psychiatry, cognitive neurology, pain, and so on. And I would really like to invite listeners, if anybody would be interested, to contact Dr. Geo or me to join our group, which are starting the research on several topics. And on this slide, I would just like to acknowledge our colleagues from the neurology department, neurosurgery, nuclear medicine, and the Feinstein Institute for Medical Research, which we collaborate in our brain metabolism research. Thank you very much.
Thank you very much, Professor Trošt, for this really nice presentation. I just want to mention that the discussion part is it's actually planned for the end of the symposium. So we're not going to have a discussion after every lecture. So I was also asked by the organizers to ask the audience to fill in the questions regarding anonymous survey, basically pertaining to basic demographic data. So you can find it on the right-hand side on the screen on the Slido application. And maybe now it's time to call back Vladimira, if that's possible.
So thank you, Dejan. I will try again. So it's work now. Can we just... Can you see it?
Yes. Now,
yes.
It's good. Yes, it's good.
Yes, it's okay. Good.
Just put it on the whole screen.
Okay.
Yeah, that would be.
Okay, thank you. I won't start again with the same. What is this?
It's a full screen.
Full screen, yes. I won't start with the whole lecture, so I will skip some slides and start again with this part of Parkinson's disease. We know that in Parkinson's disease, DBS is especially effective in motor symptoms, and that there are some patients that are really good candidates for deep brain stimulation, and the motor effects are great, and we can reduce medications, and the quality of life is much better, especially in tremor-dominant Parkinson's disease, which is really disabled for our patients, and the results are really great. And we know also for Parkinson's disease that improvement of motor symptoms is still present after 5 years, after 8 years, and after 10 years. There are a lot of studies talking about that in Parkinson's disease. Also for dystonia patients, we know that it's very good methods and improve outcome from 23 to 91 percentages of improvement in our patients. And we had one patient that couldn't talk before the brain stimulation because of the laryngeal involvement. He had generalized dystonia, he still had it, but he's very good, and after the brain stimulation he could talk. But all these symptoms are very much motor symptoms, and when we looked guidelines, we know that it's very good for patients with segmental dystonia, generalized dystonia, some types of combined dystonia, and especially for cervical dystonia patients, and that these good results are persistent after 5 years, and also after 10 years. So patients are really good after the brain stimulation. And also the genetic dystonia, like DYT6 dystonia, is really good. Now we know that it's very good for also as a candidate for deep brain stimulation and improve motor symptoms very much. But we also know that for pecan dystonia, we can start with deep brain stimulations. We start with one patient in very early phase of pecan dystonia. She had dystonic posture in jaw opening dystonia, cervical dystonia, dystonia of the left hand, and after deep brain stimulations, she improved much, and now she's 9 years after this deep brain stimulation, and she's really good, although she had this progressive disease like pecan dystonia. So we are always talking about motor symptoms, and not motor symptoms are very much important for our patients. In PD patients, we all start earlier to recognize and follow these non-motor symptoms, but in dystonia patients, it's not that was not like that. So we know for Parkinson's disease patients that non-motor symptoms like mood, cognition, sleep, pain, fatigue, etc., that are very important, and these symptoms are much more disabling for them than motor symptoms, and especially the influence on quality of life is much better than motor symptoms. So we have to follow and see what motor symptoms patients had. Also in dystonia patients, we know that dystonia is not just a movement. It's very complex. There are a lot of factors that are very important in these patients, and we now have very good measuring tools like non-motor symptom scales in Parkinson's disease, and we now recognize the frequency of these non-motor symptoms are very high, especially olfactory dysfunction, depression, gastrointestinal symptoms, urogenital dysfunction, pain, sleep disorders. So also in dystonia patients, we can see that depression is very high, very often present, especially it's connected with disease severity, marital status, body parts affected, self-esteem and body concept, and also quality of life. But other symptoms like cognition, sleep problems, pain are also very frequent in these patients. Early papers showing that there is no changing that DBS is very safe for cognition, mood, and quality of life in some patients. And we know also from our patients with dystonia, they all said that it's very stressful for them to have a new life after deep brain stimulation. And they have to adjust for new body, new symptoms. And it's very recognized also in Parkinson's disease that DBS is good for non-motor symptoms. A lot of them. In the beginning, they were talking about pain and cognitive problems, and studies show that there is good response for cognitive fluctuations also, and for sleep and gastrointestinal symptom, and also cardiovascular symptoms, and also for mood. And this paper from a group of researchers published in 2018 show us that especially for sleep, fatigue, and urinary symptoms, DBS is very good method. So we also know, and we had some studies about accuracy and location, and we know that it's very important to improve motor symptoms and also non-motor symptoms. And new techniques that are present now, like directional programming, better visualization software, new neuroimaging methods, we can plan shape of the field for stimulation. We can try to improve results of deep brain stimulation and reduce side effects that we know from previous methods. So now we also know that non-motor symptoms influence the most short-term quality of life and long-term quality of life. And in these times, personal treatment is very much important. So we have to know which non-motor symptoms have our patients and which of all these advanced therapies are the best for them. So this is personal treatment. And a recently published study have shown us that non-motor outcomes depend on STN-DBS location, especially if we looked for mood and apathy. They have shown that there were marked improvements for neurostimulation in the ventral border region of the STN, also for attention, memory, associative subregion, and for sleep problems ventral to the STN. So now with all these studies, we can really plan and we can really try to do and address each patient's individual clinical profile and to find what is the best for our patients. So with new techniques, DBS in future will be probably better. And in 2018, they published a review about non-motor effects of deep brain stimulation in dystonia. And in this paper, they recommend a systematic evaluation of both non-motor and motor feature in our patients to really improve their quality of life. So we also tried to see and we made an overview of the influence of DBS in non-motor symptoms in all neurodegenerative diseases, and we tried to find out the results of DBS in many neurodegenerative diseases that was used with DBS. In the beginning, we start to see what's going on with pain in our PD patients. In dystonia patients, we were very interesting in that part. So we found out that there was improvement in motor symptoms and quality of life, but pain was reduced in 58%. So this was the first non-motor symptoms that we tried to see in our dystonia patients, and after that we tried on 30 patients see what's going on. Most of them were with generalized dystonia, what's going on with sleep problems, and we find out that it was really reduced. Sleep problems were very reduced in our patients after deep brain stimulation, especially in those with generalized dystonia, and anxiety and depression also, and also pain. Everything was associated with depression, anxiety, and also motor scores before the deep brain stimulation. And when we looked for scale for patients 6 months after the brain stimulation, considering anxiety, depression, sleep problems, and pain, we found out that it was really improved in our patients. And also in cervical dystonia and segmental dystonia, sleep was not improved in our patients, but anxiety, depression, and pain was improved at our patients after deep brain stimulation. It was correlated with depression. And in Parkinson's disease, in the beginning, we also were interested in pain as a non-motor symptoms. We find out that we had improvement in motor symptoms and quality of life, and pain was reduced in 38%. And sleep problems was also improved in our patients in all domains, especially in quality of life and nighttime motor symptoms and daytime sleepiness and restless leg symptoms in our patients considering sleep. And after some times, we want to see what's going on in 100 patients treated with deep brain stimulation considering non-motor symptoms, and also find out that pain was reduced and sleep problems was reduced, anxiety, number of non-motor symptoms and severity of them was also reduced. And after 3 months, we saw that cardiovascular symptoms was better, and also sleep problems, gastrointestinal problems, urinary problems, sexual dysfunction was improved, and also quality of life and pain was better in our patients after 3 months. And after 6 months, we also find out that sexual problems and urinary problems were still very improved, and also pain and sleep problems. So in conclusion, DBS has in Parkinson's disease significant beneficial effect on pain, sleep, and gastrointestinal, sexual, and urological symptoms. And also cardiovascular symptoms can be proved. Also in some studies, we can see that behavioral problems can be better in our patients. Also quality of life is better in them. And in dystonia, we have to be aware much of non-motor symptoms in our patients. And it's really important. And in our research, we find out that DBS helps in relieving of pain and sleep and mood problems. And we maybe in dystonia, we need better scales for non-motor symptoms that can unify all kind of dystonia. You know, we have focal dystonia, combined dystonia, isolated, generalized, etc. So maybe uniform scales would be better for our patients and for us to follow them in better way. So we know that DBS is safe and effective treatments. We need better further studies in this area on non-motor symptoms because we want personalized individual treatments for our patients that will be the best options for them. So I also want to invite you to this 5th Rijeka Forum. Some of you are also included in this, and it will be in November this year before Croatian Neurological Congress, and it will be, both of them will be in Rijeka, so please join us there. I hope it will be in live, so thank you very much for your attention, and best regards from Rijeka. Sorry for technical problems.
Thank you very much, Vladimira, for the nice talk. And yes, we'll leave the discussion for the end of the symposium, as I already said. Now it's also my honor to introduce Rok Berlot. Rok Berlot is an assistant professor in neurology at the Department of Neurology in Ljubljana. So his main interest is in movement disorders and other neurodegenerative diseases such as dementia. And his research interest specifically is focused on MRI, specifically connectomics. Rok.
Hello, everyone. Many thanks for the opportunity to present at today's symposium. We'll focus on PD as a network disorder, and specifically ask ourselves how this could in any way affect our view of DBS as one of the treatments of PD. So why should we consider PD a network disorder? First of all, we know that the neurodegenerative process starts in the brainstem and slowly spreads via white matter pathways to affect the brain as a whole. Secondly, several neurotransmitter systems are affected along the way, and these deficits progress as the disease progresses. Again, affecting the function of the brain as a whole. Next, we've seen in the previous lecture by Professor Trošt, and also on yesterday's symposium, how metabolic alterations are affected in PD, and these are related with the clinical signs of PD as well as with treatment of the disease. Further, the white matter underpinnings of these distributed metabolic alterations are themselves affected, and again, as the disease progresses, so does white matter pathology. Further, we know that several symptoms of PD arise from dysfunction among a distributed set of regions, such as, for example, cognitive decline, and for several aspects of cognition, for example, for visual spatial function shown here, it has been shown that these different areas of the brain conspire to bring together the deficits we observed in patients with PD. So how can we view the brain as a network? The main basis for this is to investigate how individual regions of the brain are interconnected. We can do this either by studying how brain function correlates among the distinct pairs of regions across time. And we can do this non-invasively by investigating with EEG or fMRI. This is termed functional connectivity. On the other hand, we have structural connectivity. This can be investigated non-invasively using diffusion MRI. And in this case, the measure of connection between two pairs of network regions or two network nodes is a measure of the integrity of structural connection between these two areas, shown here as the connectome. So if we have this data available, co-register them to a brain atlas, a template, this can produce a connectivity matrix, which is a mathematical representation of the brain structural or functional connectome. And this can help us calculate several brain network measures that have been shown in various diseases to be meaningfully related to neurological function. So just briefly, how are structural networks affected in PD? The structural connectome in PD is affected in a disadvantageous way, meaning that there is less capacity for efficient integrated processing across distributed brain regions. And shown here in red are the differences in structural connectivity between PD patients and controls. Further, if we look at several stages of PD, for example, PD-MCI and PD, again, it is shown that the structural connectome is more disturbed in PD patients with cognitive decline. And next, this also has implications for cognitive function in PD. Some of our data suggests that whole brain network measures are associated with aspects of cognitive function, in particular with cognitive control. And further, local measures of efficiency of network topology affecting individual subcortical nuclei are again related with aspects of cognitive function. So far we've talked about correlation of correlations of the disease. Let's ask ourselves if we can in any way consider the network studies as implicative of what is driving the clinical signs of Parkinsonism. And here you see a group of 29 patients with various focal brain pathologies that exhibited Parkinsonism. Mind, this is Parkinsonism, not idiopathic Parkinson's disease we've discussed previously. So despite these regions not overlapping and having different relationships with the nigrostriatal tract, it has been shown in all these patients that they demonstrate Parkinsonism. And network studies assessing how each of these individual regions is connected to the rest of the brain, so studying functional connectivity, have shown that in these areas have something in common. Researchers have shown that they all connect to a common functional brain network. And the hotspot of this connectivity, the area that is most robustly connected to the brain regions with lesions is the claustrum, and this particular spot shown here, this part of this nucleus. So this is perhaps surprising because we don't really consider the claustrum to be driving the process of Parkinsonism, nor is it a possible therapeutic target so far. However, the group of researchers from Boston have found further support for their finding by investigating how connectivity between this particular hotspot within the claustrum and the exact location of the STN electrode in patients treated with PD, treated with DBS, how this correlates with clinical improvement. And the correlations were quite robust, meaning that indeed this area, the claustrum, could have a meaning in the pathology of in the pathogenesis of Parkinsonism, and perhaps could in future research prove even to be a beneficial target for treatment. So let's take this approach of functional connectivity to treatment with DBS. So if we treat patients with Parkinson's disease with, let's say, deep brain stimulation of the subthalamic nucleus, we target the individual nucleus, but the exact microlocations of the electrode differ vastly, as shown here in this picture. And this has implications for the effect of treatment and also for the changes in functional connectivity across the brain as a whole. Investigating how the exact location of the STN electrode is functionally connected to the rest of the brain in a normative group of healthy subjects. The group from the same group from Boston has shown that the degree of functional connectivity with the network shown here in this middle picture can predict improvement after STN-DBS in PD patient. In another study investigating structural connectivity, where Dr. Georgiev also participated, they've shown further that some certain aspects or certain pathways can predict improvement in specific symptoms in PD. For example, the connectivity between the electrode location to M1, so that the primary motor cortex, could predict improvement in tremor, while connectivity to the supplementary motor area and the frontal cortex could predict improvement in rigidity and bradykinesia. However, functional connectivity or structural connectivity can be also used not just to predict expected outcomes, but also to predict if there's a possibility of negative side effects. In a robust study investigating 2 cohorts, it was shown that the pattern of connectivity between the left subthalamic nucleus and the left prefrontal cortex can predict worsening of depressive symptoms in PD patients treated with STN-DBS. To conclude, in this slide, we've discussed that PD can be viewed as a network disorder, and that this network measures, while they might not be really efficient for making a diagnosis of PD, they are useful markers of disease progression and correlate well with symptom expression. We've seen that functional network alterations can explain specific neurological signs, such as distributed lesions across several areas causing Parkinsonism in patients with lesion-induced Parkinsonism. And finally, we've shown that network-based approaches could in future aid in personalized medicine approach to DBS by predicting positive and negative clinical outcomes. I'd like to thank all my colleagues and collaborators, and thank you all for your attention.
Thank you very much, Rok, for this nice lecture.
I think I'm going to take the podium now.
Exactly.
Dr. Gio, if you agree. To introduce and his talk on how frequency modulation can affect the brain stimulation clinical effects. Let me also say that Professor Georgiev is the leader of our deep brain stimulation team, and also very much involved in the research in deep brain stimulation topic and other neurodegenerative topics as well that run in our clinic. So please, Dr. Georgiev, we're looking forward to your talk.
Thanks for the nice introduction, Professor Trošt. So as already said, so I'm going to try to say a few words basically on frequency modulation in deep brain stimulation. The previous presenters actually set us the scene very well. So as we know, many different targets for different disorders. In general, for movement disorders, we use basically 3 targets: STN, so the subthalamic nucleus for Parkinson disease. It can also be used to treat dystonia. GPI-DBS mainly for hyperkinetic movement disorders, but is also effective in Parkinson disease, and VIM, so the ventral intermediate nucleus of the thalamus for the treatment of tremor. So when it goes to the positive effect of the deep brain stimulation, so we all know basically that is, for example, indications is late-stage Parkinson disease. The idea is to stimulate it and to treat the symptoms of Parkinson disease, dystonia and tremor, but not to produce any side effects. However, we all know that in clinical practice, very often, because of the stimulations, there are, for example, there are many different types of side effects, such as dysarthria, for example, speech fluency, disturbances, postural instability, gait difficulties, and other basically axial symptoms affected in STN-DBS PD patients, or for example, bradykinesia, micrographia, gait disturbances, and dysarthria in patients treated with GPI-DBS. It also goes for essential tremor, dysarthria, ataxia, postural instability, and other side effects. So this is something that we have to keep in mind. when operating these patients, and actually tried to find a way of optimizing DBS treatment. The usual way of stimulating, which was already basically mentioned, is the usual parameters, stimulating parameters, is a high frequency stimulation of 130 Hertz with a certain voltage or certain current and pulse width depending on the target, 60 microseconds usually for STN and 90 microseconds for GPI. So we can change many different parameters, amplitude, pulse width, and frequency. So frequency modulation, as for the purposes of this talk, refers to changing the outcome of the stimulation by changing the stimulation frequency in different disorders. I'm not going to talk about the already well-known long-term effect of deep brain stimulation in many different disorders. This is a summary table on frequency modulation in STN-DBS for Parkinson's disease. Most of these studies actually tried to use low frequency stimulation for the treatment of the axial symptoms that I've already mentioned. We'll focus on a couple of studies. In this study actually, individually optimized low frequency stimulation was found to be effective in most of the patients. So this low frequency stimulation was 80 Hertz, and in 1/4 of the patient, it was basically 60 Hertz of stimulation. In addition to the finding of the efficacy of low frequency stimulation for the treatment of optimizing the gait problems related to deep brain stimulation, the location was also similar. So the more dorsal the location of the electrode, and the more dorsal the location of the electrode, the lower frequency of stimulation was more effective in optimizing the outcome of the stimulation related to the gait abnormalities. In this study, we actually looked at the effect of low versus high frequency acute stimulation in PD patients. So it can also positively affect low frequency stimulations, such as 60 and 80 Hertz can positively affect these artery related to STN-DBS in Parkinson's disease, and specifically certain aspects of speech, such as articulation, for example, phonation and prosody, as measured by the sit-up and one-dap test. Going to tremor, is it? I think I skipped some of them. Actually, this is also so not going to tremor. Basically, going to dystonia. Also, the long-term effect of GPI DBS in dystonia in general, and also focal dystonia, has been also well established when talking about when we're talking about focal dystonia. Cervical dystonia, not so many studies about the effect of low frequency stimulation in dystonia patients. Mainly, these studies were not the objective of these studies was not to try to optimize certain side effects related to GPI DBS, but also to see if it is feasible to use low frequency stimulation in dystonia patient. In study, so target symptoms in GPI DBS would be, for example, bradykinesia. In this study, we actually showed that bradykinesia and other Parkinson, special bradykinesia and some other Parkinsonian symptoms is actually more common in GPI DBS patients on a chronic stimulation. So this is basically another, just to mention the tremor and the VIM DBS for tremor. It is also quite effective, but also different side effects can also emerge related to tremor frequency modulation. From a clinical practice, with basically what we know is that sometimes in tremor, which is resistant to the usual frequency of stimulation, 130 Hertz, a high frequency stimulation of, for example, 160 or 180 up to 200 Hertz is effective. The mechanism of action is not known. Why frequency and why frequency modulation? This is a well-known fact that bradykinesia or akinesia, is a kinetic state in patients with Parkinson's disease, relates to beta synchronization in the brain. This can be seen in recordings from the deep brain structure, such as the subthalamic nucleus, but also from the surface EEG. Basically, neuromodulation can target pathological, physiological beta bursts related to certain specific symptoms, such as the gait impairment. So basically, the idea would be to suppress these pathological rhythms by the use of certain DBS frequency, lower or higher. And it was actually already shown in electrophysiological and neurophysiological studies. And this is a study in animals, in normal rats, that beta band subthalamic nucleus DBS induces Parkinsonian-like blink abnormalities, so abnormalities in the blink reflex related to the DBS frequency. This was already mentioned by the previous presenter. How to use neuroimaging. I'm not going to mention the brain metabolism, but it actually refers to also brain metabolism. So this is, in my opinion, a way to go. So it could be used to see if different, for example, networks are activated by the use of different frequency of stimulation, by the use of the advantages of connectomic analysis in these patients. So to conclude with, it seems that frequency modulation, specifically low frequency stimulation, can reduce axial symptoms in Parkinson's disease. This is very often used in clinical practice. There is no real evidence of the effect of low frequency stimulation in Dystonian patients, and this needs to be further explored. Also, high frequency stimulation could be used in tremor, as I said, sometimes quite successful in patients in who do not respond well to the usual frequencies of stimulation. However, what is not known is that it's not the mechanism of action of frequency modulation is not really known. And there is a really lack of imaging studies alone or in combination with electrophysiological approaches that could help to understand the mechanism of action of frequency modulation in patients with deep brain stimulation. This is, of course, the major idea is to individualize and optimize the treatment in DBS patients regardless of the diagnosis. So I will finish with acknowledgements of my collaborators in Slovenia and also abroad. Thank you very much for your attention.
Thank you very much, Professor Georgiev, for this comprehensive overview. And we are going to continue now with more specific topics related to the brain stimulation in Parkinson's disease. And it's my pleasure now to introduce Tjaša Mlinarič. Tjaša is a psychologist and also a PhD student, and she will share with us some of her results of the study of impulsivity in patients with deep brain stimulation. Please, Tjaša.
Hi, everyone, from my side as well. I just want to make sure, can you see my screen, the presentation?
Yes, we can see the first slide.
Okay, and okay, yeah.
And the next one as well, thank you.
Yes, okay, thank you. Hi, everyone, again. It's my pleasure to present to you today an ongoing study at the University Medical Center of Ljubljana, where we are exploring the effects of deep brain stimulation and dopaminergic medication on impulsivity in patients with Parkinson's disease. We have heard quite something of Parkinson's disease today, so I would like to mention that besides the most obvious motor symptoms, patients with Parkinson's disease also experience a variety of non-motor symptoms, which can show as cognitive impairment or sleep disturbances or changes in mood. And besides all of those, also impulsive behavior. And this is the behavior that we are focusing on in our study. And things are usually not as simple as we would want them to be. So even impulsivity, we can recognize different domains of impulsivity. So we can talk about motor impulsivity, reflection impulsivity, and cognitive impulsivity. Motor impulsivity means the impaired inhibition of learned responses. So, for example, if we are driving a car, we know that a yellow light on a traffic sign means that we have to stop the car because the red light will follow. So this is a learned response. And then with reflection impulsivity, we usually mean fast acting. So without reflection to think about consequences. And with cognitive impulsivity, we usually mean impulsive decision-making, impulsive choices. So in gambling or with addiction, we usually see that they would prefer an immediate reward, even though it's lower than maybe a delayed and bigger reward. Previous studies show a variety of results, and they are usually contradicting. And showing different conclusions. And the reason for this inconclusiveness might be that they're using a different methodology, and also that we can recognize different impulsivities. Also, Parkinson's disease is very heterogeneous disease, and there's a lot of between subject variability. And that's why we decided in our study to test the effects of the deep brain stimulation and medication on all aspects of impulsivity, so motor, reflection, and cognitive, in just one group of patients with Parkinson's disease, so to control for this between subject variability. We used 3 tasks to check for these 3 types of impulsivity. And for motor impulsivity, we used the AX cognitive performance task, where participants see a sequence of letters, and their task is to respond every time they see A followed by X. So this is their learned response. And there are some catch trials, for example, A followed by any other letter, or X following any other letter than A. So this would be then catch trials or impulsive reactions. For reflection impulsivity, we use the beads task, where participants are presented with 2 jars. One is containing more blue beads, and the other one is containing more green beads. Computer then selects one of the jars and draws beads from the jars. And the task for the participants is to say from which jar are the drawn beads. So more impulsive patients or participants would draw less beads, so they would make decisions quicker than less impulsive participants. And for cognitive impulsivity, we implemented delay discounting task, where participants are presented with 2 choices. One of the choices is a small but immediate reward, so 10 euros today. And the other choice is a bit bigger reward after some delay, so 24 euros in 2 weeks. And then their task is to just say which of the rewards they would prefer. And then based on these rewards and the delay between them, we calculated a K value as a measure of cognitive impulsivity, with higher values meaning more impulsive participants. As already mentioned, we included 1 Parkinson's disease patient group, and we tested each patient on 4 conditions. So either with their medication on and stimulation on, or with either medication on and off and stimulation on and off, so 4 conditions altogether. They came in 2 days, because testing all 4 conditions in 1 day would be a bit overwhelming. And the order of conditions was randomized across participants, as well as the order of tasks across each condition. These are the demographics of the patient group. We included 20 patients, mean age was 61, 50% of them were female. On average, it was 2 years after their DBS stimulation, which means that stimulation was stable at that time. And on average, they had Parkinson's disease for 13 years. We also did some questionnaires to control for depression and apathy, as well as their cognitive status, and their cognitive status was preserved. So the results show that there was a significant main effect of condition on motor impulsivity, meaning that the participants made the most errors while having their stimulation on and also while having their medication. And we can see here that they made significantly more errors on AX and BX trial. These BY trials, these are control trials, just to check if they understood the task and were able to perform their tasks successfully. In the other two tasks, for reflection impulsivity, we did not find any significant effect of condition, nor did we find a significant effect in cognitive impulsivity task. So to conclude, both DBS and medication did have a significant effect on motor impulsivity, so participants making more errors on the AX task, while there was no effect of DBS or medication on reflection and cognitive impulsivity. So these results support the idea that the impulsivity is not a unitary phenomenon. So we do have multiple domains of impulsivity, which can also suggest that other types of impulsivity, so cognitive and reflection, might depend or involve other networks or neurotransmitter systems. Okay. These are the acknowledgements, and thank you for your attention.
Thank you very much, Tjaša, for this nice and interesting presentation. I'm sure it will raise many questions and thoughts, because impulsivity is something that we are very much aware and afraid of, I mean, the clinicians, but let's leave it for the discussion. The last speaker of this symposium is a young researcher, Živa Drakulić. She's a medical doctor and a PhD student, and she will present you in the next minutes the first steps of her PhD thesis research. So Živa, please.
Thank you. Can you see the slides okay?
Yes, it's fine, thank you.
Great. So my name is Živa Drakulić, and today I will present the effects of the subthalamic nucleus deep brain stimulation on language in advanced Parkinson's disease. So communication issues in Parkinson's disease are quite common. They are present in around 60 to 70% of patients. And they present as a speech, language production, and comprehension issues, such as comprehension of syntax and grammar, lower speech rate, deficits in verbal fluency, impaired processing of action words, inappropriate pausing, and impaired processing of emotional aspects of communication. My research focuses mostly on verbal fluency in action and emotion words. So verbal fluency tasks in Parkinson's disease have shown mixed results for impairment in letter-guided and semantic verbal fluency. Letter-guided fluency tests number of words beginning with a certain letter and supposedly evaluates frontal lobe function. while semantic verbal fluency tests number of words in a semantic category, for example, animals, and evaluates temporal lobe function. There are, however, robust findings for impairment in alternating verbal fluency tasks. So these are tasks where participants have to alternate between two categories of words, for example, animals and fruit. So impaired comprehension of syntax and alternating fluency deficits support a link between language deficits and executive function in Parkinson's disease. Verbal fluency tests, however, are less sensitive, and we have to examine the effects of confounders. There is an impairment in processing words that represent words representing action and emotion. And action language has been shown to be impaired in tasks such as naming, where participants are asked to name what is presented on images. Verbal fluency, where participants are asked to say words in a category in 1 minute. Lexical decision, where participants have to decide if certain words are the proper words in their language. And association tasks, where participants have to decide which word or image is most like some other word or image. So there could be a relationship between processing action words and physical movement. That would mean that PD patients have problems with processing action words because their movement is impaired. This is the main idea of the so-called embodiment theory. So as mentioned, PD patients also have issues with words representing emotion, such as impaired recognition and categorization of emotion words. There is, however, less research done on these emotion word deficits. So STN-DBS mostly affects motor areas of the STN, but stimulation can spread in surrounding brain areas and therefore affect associative and limbic circuits. Language function has been found to either improve, didn't change, or even worsened after STN-DBS. And actually, verbal fluency is most often found to be worse after STN-DBS, but this also might be some effect of surgery. DBS has been shown to improve lexical access in naming tasks. So our pilot research was focused on verbal fluency tasks in Slovene language, as they are easy to administer. The preliminary results are the first step in my doctoral research project to determine the effects of DBS on language. We included PD patients without DBS and healthy controls, and all participants were native speakers of Slovene. So we had 10 patients, PD patients, and 10 controls. The mean age was significantly different in the two cohorts, around 67 years and 72 years. The mean education length was not significantly different, and the mean length of Parkinson's disease was around 9 years. So we tested verbal fluency. Those are words spoken in 1 minute in 8 categories. In semantic fluency, we observed animals, fruit, emotion, and action words. In phonemic fluency, we observed words beginning with the letter S. And in alternating fluency, we included combinations of animals and fruit, occupation and furniture, and words beginning with K and P. We analyzed the results using ANCOVA with confounders, age, and years of education. So these are the results for the semantic categories. And we can observe there is a significant difference only for action words and not for other semantic categories. This is the result for the phonemic category. There is no significant difference. And these are the results for the alternating fluency tasks. So they were very significant for occupations and furniture, and borderline significant for animals and fruit. We would expect a higher significance for animals and fruit if we added more participants. So generally, we observed the lowest mean in number of words for emotion words, which was expected, it is a harder category, and the highest was in the animal category. So PD patients performed worse in all the tests administered, but when we corrected for age and education, the significant difference was found only in the action category and some alternating categories. So we know from literature that various language functions are impaired in Parkinson's disease, and the results in our pilot tests were mostly in line with this previous knowledge, with worse performance in action words and in alternating fluency. In my future research, I would like to include additional language tests, such as naming and lexical decision. I would also like to observe the effect of STN-DBS on language tests, and I will also add neuroimaging techniques to observe the correlation of language function and changes in brain function and structure. So thank you for your attention. I would like to thank my mentor, Professor Maja Trošt, and my co-mentor, Professor Kristina Manuilidou. Thank you.
Okay.
Thank you very much, Živa, for a very clear presentation and already some interesting results. I think we can now open the discussion, and I would like to invite all the speakers and my co-chair to join us.
Yep. So I think we should start because we don't have a lot of time, but definitely for a few questions. Maybe I'll go first with a question for Professor Trošt. Is there a possibility to use DBS as a preventive technique for Parkinson's disease?
I would say not, and then be silent for a few seconds and then say yet. I mean, currently we would not do that because deep brain stimulation is an invasive way of treatment that, although is safe and very efficient, it does. It also has its possible side effects, which can be quite serious, and we would not want to operate on someone who has clear indications that are agreed upon now. But we do notice that deep brain stimulation and other continuous treatments for advanced Parkinson's disease are being introduced to patients earlier than maybe 10, 15 years ago. So we are heading towards earlier stages of the disease, but I think we're still very far from the preclinical steps, because we would have to invest into much more research on how can we intervene with preclinical stages of Parkinson's disease, and hopefully a less invasive types of treatments would be available rather soon.
Yeah, and another question for you, Professor Trošt. Could one use information about the expression of metabolic brain patterns to predict the response of DBS in PD patients? So it relates to the prediction of the effect of DBS in PD patients.
The current patterns that we have, and we can also use in our clinical and also research work, are actually patterns of the advanced expressed disease. We also know the pattern about some preclinical forms, preclinical diseases or disorders they may develop into Parkinson's disease. Like example, we have a pattern from REM, sleep behavior disorder, which is a very strong risk factor to develop Parkinson's disease and other synucleinopathies. But based on those, we can for now only expect or predict the development of one of the other of these diseases, but not the possible effect of various treatments, at least for now not.
Mm-hmm. Okay, thank you very much. And maybe another question which relates to the questions for Professor Trošt, and it goes for Dr. Berlot. Based on the connectivity studies in PD, is the subthalamic nucleus the right target to stimulate, or would you expect better results by stimulating other brain targets, and if so, which? So what do you think, Rok, is there a better target based on the connectivity studies in PD as a better target for deep brain stimulation? Mm-hmm.
Yeah, that's a great and thought-provoking question. First of all, we have to ask ourselves: our connectivity studies, functional connectivity studies, are presented at the point where where we could definitely, with confidence, reply to these questions? I would say no, but they can give us ideas to explore further, which can be done. And the question of whether STN is the best target, based on available data, we can already partly answer it. It is the best target for certain symptoms of PD, but we've seen that for others, such as tremor, dyskinesia, other targets are more suitable to the task. However, the thought-provoking idea of the study I presented is that it implicated in the expression of Parkinsonism, not PD, but Parkinsonism in general, a region that has not been tested yet with deep brain stimulation. And this gives us hopes, not just to find a new treatment target for patients with Parkinson's disease, but perhaps also to explore DBS in new pathologies. I have not shown this set of data, but it was shown that the claustrum is highly correlated with the pattern of atrophy in some atypical Parkinsonisms, which are poorly responsive to levodopa. And this suggests that perhaps this could be, there could be in future a trial targeting this area or other area pointed out by functional connectivity studies in a new group of patients.
Okay, thanks. And I have another question for Professor Vuletić. Do you think that non-motor symptoms could be the main indication for DBS in PD and even in dystonia patients? So this is a nice question. I think, Vladimira, what do you say?
So not the main indication, but it will be for sure the main indication for choosing target and shape of the stimulation field, due to these effects of different parts of STN or GPR on non-motor symptoms. But if we want to have precise and personalized treatment of our patients, if it will be for sure very important, should we do DBS or should we do pumps due to these symptoms as imperative for better improvement of quality of life. So we know now for some non-motor symptoms that DBS is better, for some of them that pump is better. And also maybe we will be brave and do DBS early if we know that there are some non-motor symptoms that are very influenced on quality of life beside motor symptoms, and do deep brain stimulation early in our patients. I can't hear you.
So thank you very much for the answer. Now I'll give the
Yes, there is just a question from the audience. Can deep brain stimulation be used for the treatment of epilepsy, maybe in children? Professor Vuletić, is for you.
Epilepsy, so of course there are centers that are doing that for epilepsy, and the results are not so good as in movement disorders, but the improvement is the reduction of of attacks, epileptic attacks in patients can be seen there, and also especially in these refractory, pharmacological refractory epileptic seizures, and when there are no other possibilities. But also we are doing deep brain stimulation in children in dystonia patients. We had now one patient with this device 6, the child was 7 years old. We have a lot of patients for dystonia that we are dealing with, and we treat them with deep brain stimulation. But for epileptic patients, I'm not so good enough to talk about epileptic patients and children. I know for adult patients that there are some patients with good results, but not constant in all research. So I would say that there are centers that are excellent there. They have many patients, but not so wide present as for movement disorders.
Thank you very much, Vladimira. Dr. Gear, would you just want to add something to that? Because now in our centers, we have a couple of conversation about deep brain surgery for epilepsy. Yes or no? Should we start it? Shall we not?
Well, I think it works definitely. There are studies on the good efficacy, basically, of DBS in epilepsy. So I think it's a good idea, but it has to be incorporated within the center for epilepsy, and of course, one has to take into account. Actually, it's basically for quite specific group of patients, or subgroup of patients with epilepsy, not for all the patients. And after exhausting all the other therapeutic possibilities, then yes, it can be offered to patients with pharmacoresistant epilepsy.
Thank you. There is one question regarding the first part of our symposium, and this: is it possible to get DBS for non-motor symptoms and diseases in Slovenia or neighboring countries? If I may to start, and then everybody's welcome to add. I'm not sure whether this question is in connection with Parkinson's disease and like non-motor symptoms in Parkinson's disease. I mean, specifically for non-motor symptoms of Parkinson's disease, if the motor condition of patient is well, we probably wouldn't do deep brain stimulation. But we also take into account the whole clinical picture of Parkinsonian patients, so motor and non-motor symptoms as well. And what we actually look for and judge, so to say, is the patient's quality of life. And if the team of people who finally decides whether the patient is a good candidate, should expect improvement, would decide that yes, this patient, although non-motor symptoms are more pronounced maybe than the motor ones, maybe I wouldn't say absolutely no, but I think that all centers are nowadays following the same clinical criteria regarding the selection of the patients, and I don't think that's much difference between the countries, at least not in Europe. Vladimira, would you want to add anything to that?
No, as I said before, we still watch first motor symptoms to choose our patients are good for invasive methods, but non-motor symptoms are those that, as you said, will give us more insights on the state of our patients, and we will be able to easier decide what treatment should we do, and maybe in early stage if there are some problems with sleep and etc., but also motor symptoms present at our patients that are not good tolerated and good control with medication. We will do this earlier, as if we know that DBS is good for that or other invasive methods.
Thank you very much. Now I would like to ask Professor Georgiev, would the low frequency stimulation also cause some specific side effects if it would be used for conditions for which it performs better than high frequency stimulation? Are there any particular side effects that we should be aware of if the patient would be?
Yeah, this is a really nice question. Yeah, this is a really nice question, because if low frequency stimulation actually causes, for example, some side effects that you wouldn't see in high frequency stimulation, then one would say that there is a kind of a specific effect of the stimulation, so it works in a way. So yes, there is. For example, quite a very low frequency of stimulation in Parkinson's disease produces, it can make bradykinesia more severe. So it can worsen bradykinesia. So if you would use, for example, 60, 40 hertz of stimulation, so definitely 40 or 20 hertz of stimulation, it definitely worsens bradyhypokinesia. And what we've noticed in one of the studies on frequency modulation, we've actually noticed that very often patients with Parkinson's disease are not able to tolerate frequencies lower than 40 hertz of stimulation, actually lower than 60 hertz of stimulation. So even 60 hertz is kind of a borderline frequency that the patients could tolerate. So I believe there is a specific effect of the frequency of stimulation, and moreover, maybe exploring other types of stimulating patterns, not single frequency, but more complex stimulating patterns. I don't know, such as theta burst stimulation. This has actually been tried in animals, and it has been proven to work in animals, and also changing the waveform of stimulation. Instead of using square wave pulse, for example, using a more sinusoidal type of pulse, and so on and so forth. So I think it's an important field of research in order to optimize the DBS treatment.
Thank you very much for this question. There is a question for Živa Drakulić, and it is, do you think that there could be a possible connection between action words processing and the mirror neural system? Can the mirror neural system be impacting in patients with Parkinson's disease? That's very straight to the point, Živa.
I think it's a very interesting question. I haven't looked into how the mirror neurons might impact both action and potentially emotion language processing. But considering how widely the functional network can be disturbed in Parkinson's disease, I think it's definitely one of the things that has potential to. And I would happily look into this for my research.
Thank you, Živa. And if I may ask Tjaša something, when I was mentioning that we clinicians are afraid of impulsivity after deep brain stimulation, it mostly comes from the, I would say, older ages of deep brain stimulation, when there was a fear that deep brain stimulation may be connected with the higher incidence of suicide, at least after the first year of DBS treatment. As I understand, your results would not go in line with this idea. Even we know nowadays that probably the cause for this suicide increased rates were decreased doses of oral treatment, but even your results would also convince us against it, because motor impulsivity is something much different than emotional or cognitive one that would be needed for someone to harm himself or herself. Is that right?
Yeah, I would think so. And I also think that maybe taking their own life would be more related to other aspects and not the impulsivity itself. Because what I've seen from talking with the patients with DBS, some have very high expectancy of, I mean, they expect a lot from the DBS. They think that, I don't know, it will treat all of their problems, and it's not always that successful. So maybe I would relate it more to that those that their expectations don't get reached, that maybe they have more problems with that. So I wouldn't relate this to impulsivity itself.
Thank you very much, Tjaša. I think we will have to wrap up with our discussion because we are running a little over time. If people would still want us to answer questions, please send us to us and we will answer them later. Maybe just one very practical question, whether deep brain stimulation can be performed in hospital or in outpatient service. It's a short hospitalization is needed actually. But although I've heard that in US in some centers they do it in outpatient basis, but it may be difficult for the patient. So in the last seconds, I would like to thank very much the audience, the speakers for the lectures and this fruitful discussion. And I hope we will meet again at the next Synapsa Symposium with even more results of our exciting research. Thank you very much, everybody, and good luck.